Michael Chernew, thank you very much indeed for talking to me this afternoon.
It's wonderful to be here.
I understand in your presentation later today you're going to be touching on some of the different payment systems that are used in the United States to promote integrated care. Could you give us a quick overview about how some of those payment systems work?
Certainly, although I think in the US we don't think of the payment systems designed to promote integrated care. We think of integration as a mechanism that's necessary to support the payment system. And as in many places, including here in the UK, there's a history of fee-for-service care. And there's real concern in the United States that a fee-for-service payment mechanism creates a series of incentives that makes care both more expensive than it need be and also impedes the delivery of high-quality care. So the notion in the United States is that by reforming the payment system to incorporate a broader set of services, you can both control spending and improve quality. However, when you broaden the set of payment to be more than just for a particular service, but say for an entire episode of care or for an entire person, it's important that the organization that receives that payment be able to manage the money that they're now getting, that instead of simply covering a particular service, say a diagnostic test or a visit, but is now intended to cover an entire range of care. In order to manage that, the organization must integrate a series of specialized providers. So there has to be a connection between the hospital and the post-acute providers. There needs to be a connection between the primary care providers and the specialists. There needs to be a connection between the physicians and the hospital. And so once you change the payment system to provide incentives for both higher quality and to control spending, you must change the organizations that receive that payment in a way that enables them to be successful, and that requires some aspects of integration. And so in the United States, there is a mad rush for healthcare delivery systems and organizations to integrate in a variety of ways where groups of providers that traditionally have not been connected to find ways to connect.
And is there much evidence yet that this is feasible and that you are able to contain costs and improve quality?
Let's start with a simpler feasible question. Can you actually make it work? So there are a number of examples in the United States. There's one in Massachusetts that I've studied quite a lot that demonstrates that it physically can work, that you can pay a broader bundle of payment and that the organizations can in fact come together, accept the money, and work without disaster occurring. The evidence, at least in the example in Massachusetts, which I studied, suggests that in fact quality did get better. And I might add that in that example, this new payment model was coupled with a strong pay-for-performance component. And in fact, the organizations that accepted payment under the system did in fact improve quality and reap benefits because of that.
Can you tell us a bit more about how you develop these bundled payments and whether there are any pitfalls we need to be careful about?
Well, again, in the United States, and I should tell you, I am privileged not to be developing any specific payments, but there's a large number of organizations in the United States that are experimenting with different versions. And let me draw a distinction between two different types of bundled payment. One type is typically considered an episode payment. So an delivery organization, typically an integrated delivery organization, would be paid for an episode of care. That could be an episode of knee surgery or back surgery or treatment for a heart attack or a chronic condition like diabetes. But there would be an episode of care and there would be payment paid to a provider system for that episode. Most individuals, of course, will have multiple episodes. So you could have diabetes and heart failure and need hip surgery. And so an organization conceivably could receiving multiple episode payments. And it's difficult to assess what the appropriate level would be and how to adjust for the fact that multiple episodes may be ongoing. So that's one challenge. An alternative type of bundled payment is really like capitation, where an organization agrees to accept a fixed amount of money for an entire person's care over the point of time. That's much easier to implement, although again there's a lot of challenges, and I probably can't name them all, but amongst the most important is how the underlying provider system manages risk and how you risk adjust the payment system. So the question becomes, if I want to pay an organization a certain amount of money to care for Gerard, I have to decide how much money that is, and should they get more for caring for Gerard or caring for me if we happen to be different. And if they don't do a good job, how much risk are they facing? So one reason why the organizations have had to change in response to these payment systems is because now they have to manage this risk. There's other things that are involved in these systems. People are very concerned that if you bundle payments, say at a capitated level, the organizations will have an incentive to not deliver care, so there's a concern that quality will suffer and access will suffer, so they're typically coupled with pay-per-performance type systems. There's a concern that if the organization does very well and reduces utilization in response to the new payment system, that the next year the payer will come back and reduce the payment and thereby capture all the savings. So there's a question about how to make these things work over the long run and how to update the fees over time. And there's a big issue about the data that has to flow across these organizations so that the different components within this integrated organization know what's going on. And there's different types of data that have been given. Some of it's very real-time clinical data where GPs are told that their patients end up in the emergency room, so they might do something prior to an admission. So very detailed real-time clinical data. And other times there's broader managerial data that's conveyed. For example, an organization might be told that their rate of utilization of imaging is 30% higher than the average, so they might be able to develop a program to manage imaging. And all of that data is flowing across organizations where the underlying components of that organization have different incentives, different cultures, and things of that nature. So it's challenging not only to develop the rates, know what the right level is, but also to develop the information flows and the other types of infrastructure that is necessary to make this broader type of payment work. And in the US, a lot of experimentation is going on, and it remains to be seen the extent to which these types of models can be successful outside of the few sentinel places that are sort of prepared to do this.
Thank you. As you know, today's conference is all about competition and collaboration.
Right.
There's some skepticism out there whether the two are actually mutually compatible. Do you have a view on that?
Well, I do think that they can be compatible. The challenge, of course, is are they compatible in different types of markets? So again, speaking in the United States, if you were in Los Angeles, you could envision multiple integrated systems competing against one another. But if you were in Kalamazoo, Michigan, that might be harder to envision. And if you were in Fargo, North Dakota, even harder potentially.
Just because of the geographical distances.
The differences in the population sizes. So in a place that's big, that can support a lot of different systems, you could envision this amount of competition working across integrated systems. There's still problems. You know, I'm in Boston, which is a big place. And you could envision competing delivery systems in Boston. In fact, we have competing delivery systems in Boston. But it remains to be seen how to set up the models to make sure that individuals that make choices, perhaps when they're purchasing an insurance, are then enforceable when they go to seek their care. So if I commit, when I say purchase my insurance, to work in one delivery system, and then I become ill and decide that my particular illness is better treated in another delivery system, what set of constraints do I face if I want to switch? And if I face no constraints, what incentive is there for me in the first place to care about my choice? So setting up any system of competition is contingent on the incentives that individuals face. And it always becomes important for individuals to be forced to pay a price if they want to make a different choice. The problem is, particularly in healthcare, we're sometimes hesitant to enforce that price once they become ill. Because we're skeptical that they knew everything they needed to know in the beginning. Health is a very personal decision. And so it really becomes a challenge as to the extent to which you're going to allow people to make choices and then force them to live with those choices after the fact.